Good day, fellow learners. Once again, this is your mentor, Gapuz, your fact check buddy, joining you for another teaching and learning session, this time around about vaccination, specifically your MMR or your measles, mumps, and rubella vaccine. Okay, so the question is, can MMR vaccine be administered to a patient with allergy to eggs? Now, let's have an overview of your MMR vaccine. So first and foremost, pay particular attention to the fact that your MMR vaccine is a live attenuated virus vaccine. Attenuated means the virus is weakened. Therefore, even if the virus is weakened, it has the potential to cause an infection, albeit harmless one. So it simply means it can cause a harmless infection to the vaccinated person. So that's how the vaccine will exert its effect on the vaccinated person. Now, the contention is, in the olden times, not really long ago, your MMR vaccine specifically is produced using chicken embryo. So therefore, there is the potential that if a person is at risk, or if the person has allergic reaction to chicken eggs, then there's a great chance that they could also be having the same allergic reaction to MMR vaccine, which is during those times produced through your chicken embryo. So therefore, what happens now with the more modern methods of producing the vaccine? Well, modern MMR vaccines contain insignificant or no egg protein at all. So they're no longer inoculated from chicken eggs, or I've came across an old literature that some are even inoculated from duck eggs. So the modern vaccines for MMR no longer contain egg protein. So that answers the question. So before we move on any further, let me begin with a disclaimer. And of course, I'd like to ask you to join me in this mission. Our goal is to provide free NCLEX RN application and review to 100 nurses. We've done that last year. We'd like to do this again. And to help us achieve this, just watch and finish the ads in our videos. There's no need to do anything. But for those of you who are kind enough to share our videos to at least 10 of your friends, you're going to receive additional prayers from our mentors team at the Gapuz Test Prep Center. And we'll pray and we'll assist you that you'll pass the test with minimum of 75 items at the fastest rate that you can. Okay? So thank you in advance for not skipping the ads. Okay? So back to the question, can MMR vaccine be administered to a patient with allergy to eggs? Now, according to the Centers for Disease Control, MMR can be safely administered to patients with severe allergy to eggs or egg proteins because the modern MMR vaccines, as we've talked about early on, a while back actually, no longer contain egg protein. Okay? So if you're reading your old literatures, you can actually update it based on this current guidelines from the CDC. So let's talk about your MMR vaccine. So MMR vaccine may provide some protection for measles if given within 72 hours of measles exposure. And according to the Centers for Disease Control, 2 doses of measles containing vaccine are administered at 12 to 15 months, and the second dose at 4 to 6 years of age. And that's what they usually consider as booster dose. However, people who are working in sea vessels like a cruise ship would usually be required to have 2 doses with 28 days interval before they board the ship. Okay, so that's actually a form of a prophylaxis, okay, or vaccination, revaccination for people who are actually working in sea vessels. So according to the Centers for Disease Control, 2 doses of measles containing vaccine can be administered to people with HIV infection for as long as they are not severely immunocompromised. Let me qualify that. So first and foremost, remember, people who are severely immunocompromised and they are HIV positive should not receive measles vaccine, because measles vaccine is live attenuated virus vaccine, which means it has the capability to cause a milder, harmless infection to the vaccinated person. So for the immunocompromised HIV positive patient, that could cause more harm. Okay, so people with HIV infection can receive your MMR vaccine provided they're not severely immunocompromised. Household and close contact of immunocompromised patients, which simply means the caregiver of a patient with cancer undergoing a chemotherapy should be given, okay, 2 doses of measles containing vaccine. And then healthcare personnel, international travelers, and post-high school students. Now, according also to the Centers for Disease Control, MMR is not given to those with severe allergy to the vaccine component, as evidenced by a life-threatening reaction that they could have experienced after the first dose was given to them. Then those who had life-threatening reaction to the antibiotic neomycin, pay particular attention to that specific concept. Those who are severely immunocompromised, meaning those who are undergoing chemotherapy, HIV positive with severe immunodeficiency, and the pregnant patient. So according to the Centers for Disease Control, precautions for MMR include history of thrombocytopenia, personal or family history of seizures, need for tuberculin skin testing, or recent receipt of antibody-containing blood products. So it simply means that the healthcare provider should be informed of the presence of these conditions, and the patient would further be evaluated before a decision is made whether MMR vaccine will be given or not. Okay, according also to the Centers for Disease Control, side effects of MMR vaccine include soreness at the site of injection, fever, mild rash, and temporary joint pain and stiffness. So using the functional concepts we just learned, let's try answering a sample question. Remember this question, colleagues. Fair warning, measles, mumps, and rubella vaccine is not given to which of the following patients? Severely immunocompromised HIV positive patient, yes, we talk about that. With allergy to neomycin, that's your antibiotic, yes. Had severe life-threatening allergic reaction with the first dose, yes. Undergoing chemotherapy, yes. Pregnant, yes. And with allergy to eggs, no. The MMR vaccine can be given to patients with allergy to eggs. Okay, so we put an X. Therefore, thank you very much for joining me in this video. And let's learn together. If you have any request in terms of concepts that you have difficulty understanding, please feel free to send me a request through my email, mentor.raygapuz@gmail.com. Let's begin with the concept of osteitis deformans. You know, the first time I discussed this to a group whom I've mentored the previous week, they gave me this, the Gollum look, and people are telling me, sir, we are in the Philippines. That thing seems Greek to us, seems it's out of space. Now, osteitis deformans is actually Paget's disease of bone, which means that it is a chronic condition characterized by rapid breakdown and then rapid regrowth of bone. So which simply means you've just had a fracture and then you have yet to align it, okay, probably through a cast or through a traction, and the bone has already regrowth, so giving rise to deformed bones, and that could usually occur in different parts of the body. So the exact cause is unknown, and definitely there's no cure. However, there are medications. Those medications that are usually being used for osteoporosis, called biphosphonates, like alendronate or Fosamax, bisidronate or Actonel. These medications are also given to patients with osteitis deformans. Now, those who are asking if there's a possibility that there could be familial predisposition to the condition? Yes. In fact, approximately the 10 to 50% of those cases with familial pattern could be associated with a mutated gene. However, there are also those conditions, same ostitis deformans, but with no familial pattern, which means there's no history in the family, and this could account for approximately 5 to 30%. Given that your ostitis deformans eventually leads to a deformed bone, so what would be our priority nursing diagnosis? So we can say that the patient could be, since they have deformed bones, they may not be able to properly move themselves, and that increases the risk for injury. So here's a functional concept. An ostitis deformans risk for injury is the priority nursing diagnosis. Using that functional concept, let's answer a question, but just to give you an idea how ostitis deformans looks like. So here's a patient, okay, with deformed bones, okay. So the nurse is providing care to a client with ostitis deformans. Which of the following nursing diagnoses should the nurse address first? Okay, so is it 1, altered tissue perfusion, 2, impaired mobility, 3, risk for injury, and 4, altered thought process? The correct answer would be risk for injury. Way to go. So let's try answering a sample question. Here we go. Which of the following statements related to ostitis deformans are true? It is an acute condition. We put an X. It's a chronic condition, maybe genetic or familial. Yes. Currently, there's no cure. Yes. It is related to menopause. That's osteoporosis and not ostitis deformans. Some cases do not have familial history. Yes, we've talked about that early on. And alendronate can be used as treatment. That's another yes. So we put a check on that. So for today's good news, we'd like to say congratulations to Rita Fatima B. Valencia of Central Escolar University for passing the NCLEX RN for the State Board of Illinois last September 9, 2021. And I'm so proud to claim that I mentored her on a one-on-one basis. Okay, so here is her message. Hi, Sir, good day, and have a blessed Sunday po. Just want to thank you. I finally passed the NCLEX RN. Sobrang thankful po ako sa RAG-RC since my local board sa inyo po ako nag-review. Thanks also to Ma'am Jem, Ma'am Kai, Ma'am Army, Ma'am Juliet, and all the staff. May you continue to share our talents to aspiring nurses like me to achieve their American dreams to come true. Stay safe and healthy. May God bless you more, Sir Ray. Congratulations once again, Fatima. And thank you for the trust. And they are all passing from the local RN to the NCLEX RN. So thank you for the trust, Fatima. I hope to see you turn your great American dreams to reality. Now let's begin with pressure injury pointers. Now some of you may not be so focused about knowing certain things about the care of a client with pressure injury. This used to be known as your bed sore or pressure sore. It's known as pressure injury. Okay, they're one and the same, just different names. So here's a functional concept. Remember, a functional concept could be a word, a sentence, a phrase, or even a paragraph that helps you deconstruct questions on the actual test. Here we go. Let's begin with the first one. Pressure injury. Okay, injuries rather are injuries to the skin and underlying tissues. So as they say, the skin is the first line of the body's defense against infection. So a broken skin, therefore, increases the risk for the client to develop infection. So if you'll be asked, what is the priority nursing diagnosis for a client with pressure injuries, you could potentially answer risk for infection, okay? And the risk doubles if you talk about the population who are either very young, below 1 year old, or very old, above 60. So in essence, if you have a patient who is an elderly, there's always a risk, especially if they're bedridden or if they're debilitated, okay? Because of the shearing force, there's an increased risk for them to develop pressure injuries. Let's move on. So the highest priority in the prevention of pressure ulcer is frequent, regular change in position. Talk about changing the patient's position every 1 to 2 hours. And that should be done regularly, because it's exposure to sustained pressure that increases the risk for the development of pressure injuries. So, who are the patients who are at risk to develop pressure injuries? These are your wheelchair-bound patients, remember, wanted, the aging adult, the clients with neurological conditions like Alzheimer's disease, those who have been exposed for a long period of time to pressure, too long exposure to pressure, excretion problems, those who are bowel and bladder incontinent. Remember, they get skin maceration because of the exposure to the acids, okay, from the urine and the feces. And of course, those with diabetes or they have nutritional deficiency. Once again, the code wanted. Wheelchair-bound patient, the aging adult, clients with neurological conditions like Alzheimer's disease, those who have had too long exposure to pressure, those with excretion problems, including bowel or bladder problems like incontinence, and those with diabetes or deficient in nutrition. Okay, so take note, clients who are on a low protein diet would usually have decreased colloid osmotic pressure that causes the shifting of fluid into the peripheral, okay, system. So what happens now is that there's going to be edema, and an edematous area of the body is most at risk to pressure injury. So once the fluid shifts from intravascular to interstitial or extracellular or extravascular area, so that could be a danger for the development of pressure injury. So if you would want to find out the relationship between laboratory data and the development of pressure injury, pay particular attention to the amount of albumin, because a decreased albumin levels could mean decreased colloid osmotic pressure, and that leads to edema formation, which increases the risk for pressure injury. Okay, let's move on. So the elderly client is at risk to develop pressure injury due to shearing force. So if you'll be having a question that says, which of the following clients is most at risk to pressure injury development? So you could focus on anyone who is above 60 and who is bedridden. That's because of the shearing force, okay? That's the force that is exerted on the skin, the presence of the linen, especially if the client is on a semi or high Fowler's position, okay? So because of the shearing force as they slid down the bed, so there's a risk for the development of pressure injury. Okay, now there are 4 different stages, okay? We have stage 1, in which there's no open wound, you just have a reddened skin. In dark-skinned clients, it will have a different color. So there's no blanching, the skin looks warmer. So this is just like sunburn, okay? Now, for stage 1 patients, this is managed with frequent change in position. They are allowed to use pillow for support, use of mild soap and water, as well as the use of foam and moisturizer. Now, avoid shear or pressure. So once again, you have to make sure that the patient who is bedridden is not sliding down the bed, because that would increase the pressure due to the shearing force on the skin, okay? So can you delegate the care of a patient with stage 1 pressure ulcer to the unlicensed assisted personnel? The answer is yes, you can. Okay, for stage 2, you have an open wound, an ulcer that is painful and tender. Focus on this class, blister with clear fluid. It's like, you know, a second-degree burn. So in this stage, there's also a crater. So which means there's already an injury to the skin. So this is usually cleaned with saline solution, and you have to avoid hydrogen peroxide at this point, because hydrogen peroxide may potentially, okay, cause debridement of the skin. So cover with special dressing gel or foam, and the petroleum jelly could be applied, as well as an antibiotic ointment. So you just have to keep it clean, and the dressing that's used would be your hydrocolloid dressing. So it just gives the appropriate amount of moisture necessary for wound healing to occur. This is a little bit of a challenge, especially if you have patients with diabetes, okay? So stage 3, this time the sore extends under the skin. So there's going to be fat exposure and tunneling occurs. When you say tunneling, okay, so the pus that could be underneath the skin is going to bore a hole into the adjoining or surrounding tissues, and that's when a tunnel is created. Okay, so when you have a stage 3 pressure ulcer, you have an opening, so avoid massaging the area. Of course, it needed to be debrided and then eventually dressed. Then you have to provide proper nutrition. That's going to be high protein diet to promote wound healing and keep the patient hydrated to keep the skin moist, because a dry skin could be more at risk to infection. And then keep the head of the bed low, once again, to prevent shearing force. Stage 4 occurs when you have a deep injury that affects muscles and the bones. And this is usually treated with, once again, debridement and dressing. Okay, so what if in the item, when you're answering a question, you're shown a picture such as this? So it's different when you just memorize the characteristics than when you're given a picture. So don't forget this, class. For those who are taking the NCLEX, this one thing I bet you have to remember. So this picture tells us that this is a stage 3 pressure ulcer on the hip. Okay, and with this, you have to avoid massaging the area. Okay, so your priority nursing diagnosis could be impaired skin integrity. Now, this is a stage 4 when you already have exposure of the bone and, of course, affectation of the muscles. Okay, so this is very deep and it needed to be treated properly. It has to be debrided and dressed properly and eventually treated with potential skin grafting. Okay, so document with when a wound changes category. So you have to be descriptive. Describe how a stage 1 progressed to stage 2. Or you can also describe how a stage 2 eventually is healing. The key word when you're doing a documentation of pressure injury is that you have to describe the wound. Describe it. Don't just label it and say the wound is healing. That's not a good thing. That's not a good documentation. You have to use terminologies to describe how the edges of the wounds are approximating, how the wounds could be moist, describe the color, the characteristics. If there's a foul odor, do so. So having that functional concept in mind, let's use that to question on the test. So the nurse is assessing a client's pressure injury. Upon examination of the wound, the nurse notes that the bone, muscles, and cartilage are no longer exposed, as were previously noted. So if the bones and the muscles used to be exposed, so you're talking about previously this is a stage 4 pressure injury, and now a layer of fat is however visible. So you just have a layer of fat there that's being exposed. And then here's the question: which documentation entry best describes the correct way of documenting the improvement in the patient's pressure injury? The wound has improved from stage 4 to stage 3. Even if this is correct, this is not descriptive enough. So what might others consider a stage 4 may not be the same staging criteria that you have in mind. So it's very important that you have to be descriptive. How would you know that a stage 4 pressure ulcer has improved to stage 3? Okay, reddish skin surrounds the ulcer on the sacral area, which is approximately 1.5 centimeter in diameter. Previous exposure of bone, cartilage, or muscles no longer noted. This is very descriptive. Some fat cells are visible. Okay, 3. The pressure injury has gone from stage 4 to stage 3 in a week's time. Great progress in healing noted. Well, the word great is a matter of opinion. Okay. What might be great for you might not necessarily be great for others. So this is very subjective. It's not objective enough. So we can discard that option. 4. Wound healing is taking place as predicted due to the great care of the nurse. Wow, we have a hero. A nurse who knows how to predict what's going to happen. And look, this documentation is not about the patient. It's about, praising the nurse. And this at this point in time, this is not about us, colleagues. This is supposed to be about the patient's recovery. So the best answer would be option 2. Reddish skin surrounds the ulcer on the sacral area, which is approximately 1.5 centimeter in diameter. Previous exposure of bone, cartilage, or muscles no longer noted. Some fat cells visible. Okay, so always remember the functional concept. Care of the patient with stage 1 pressure ulcer can be delegated to the unlicensed assistive personnel. Why is that so? You don't have an open wound for stage 1. You just have redness. So you have to make sure the client's turned regularly, so to prevent it from progressing any further. So here's another functional concept. Do not document other skin injury with other etiology other than pressure injury. So if you're being asked to monitor the progress of the injury of the client, specifically the pressure injury, just focus on assessing the pressure injury. Don't assess for the rashes that the patient could have due to an allergic reaction. Don't mention about the patient's scabs associated with chickenpox maybe, because you just have to focus on the pressure injury if you are supposed to documenting just the progress of the pressure injury. So let's summarize what we've learned. So you have stage 1, pressure injury, when there's non-blanching redded intact skin. So non-blanching means when you press on the skin, it doesn't turn into its original color. Okay, and then stage 2, partial thickness, so loss of skin without slough, shallow open ulcer, but this time you have a blister with white or yellow eschar. So the blister is the keyword for stage 2, just like second-degree burns with a blister. Stage 3, you have a deep ulcer with white-yellow eschar. We say eschar, these are tissues with no blood supply, or simply dead tissues. Full-thickness skin loss with slough, no bone, muscle, tendon exposure. So stage 3, you just have exposure of fats, maybe, but no bone, muscle, and tendon exposure. Once you have exposure of the bone, muscle, and tendon, then that's going to be stage 4, when you have black and brown eschar. Okay, then you have DTI. It's not the Department of Trade, guys. It's deep tissue injury. Okay, you have a maroon or purple intact skin. However, you have a blood-filled blister. And the danger is that when this pops out, you have a break in the skin, and the more that the patient will become at risk for infection. And then you have what we term as unstageable. So it's going to be like a mixture of characteristics of these previous stages, like there's gray, green, brown, black eschar. There's full tissue loss with base of the ulcer covered with slough. Okay, so what is important to note here is that there's a mixture of a stage 2, 3, and 4 in one. Okay, pressure injury, so that's called unstageable. So you would know that there's an unstageable pressure injury when you get to see these groups of skin discoloration. You have gray, green, brown, or black eschar. So you would notice that in stage 2, you just have white or yellow eschar. That's also true for stage 3. And for stage 4, you have black or brown eschar. Now, if there's going to be a mixture like black, brown, green, gray, so the green could have been yellow that has progressed into a more intense infection. So this is now something that we could term unstageable. Okay? So pressure injury may develop in bony areas of the body, such as the back of the head, back, the shoulder, the elbow, the buttocks, the hips, the heels, and ankles. But when you're answering question in SATA format related to the parts of the body which are most at risk for the development of pressure injury, please note the patient's position. If the client is lying on his back, then this could be the areas that are at risk. But if the patient could be side lying and the patient's not changing the position properly, then it could be that the back of the head could not be the one that could be at risk, but it could be the area on the ears. Of course, you have the shoulder, specifically here, near the acromion process. And then, of course, the side of not necessarily the buttocks, but the hips, okay? And then the ankles. Okay, so you have to pay particular attention on how the patient is lying on bed before you even decide to put a click on any of those choices in your test. Okay, so this is when the patient's lying on the back. Look, back of the head, you have the shoulders, you have the elbow, you have the buttocks, you have the heels, and of course the hips. Okay, so prevention of pressure injury would include avoiding slipping or sliding on bed because of the shearing force. And this is important, especially when you have elderly clients. And then using powder on the sheets, then losing weight, because tremendous amount of weight could actually put pressure on some parts of the body. And then, of course, avoid massaging the area near the injury, especially if that's already stage 3, you don't massage it. Then avoiding the use of donut-shaped or ring-shaped cushions because it would exert pressure on the surrounding tissues. Okay, so even if you are protecting the area of injury, the surrounding tissues could be hard pressed when you're using a donut shape or ring shape cushion, especially when you have a wheelchaired patient. Okay, so observing any of the following needs, reporting to the healthcare provider. If you observe foul odor, pus, redness or tenderness, swollen skin, and fever, you have to document this when a patient is endorsed to you, especially with these conditions that are already showing. So in other words, when you have this, as the patient is endorsed to you, make sure you document it properly. Okay, you can even take pictures so that comes with the picture, you have to describe how the skin looks like when the patient was endorsed to you. Okay, so once again, it's shout out time. Congratulations to Chantel Victoria Toralba of Holy Name University in Bohol for passing the Texas Board of Nursing last January 29, 2021. Thank you for the trust and for choosing Ray 8 Gapuz review system. So here's your mentor, Ray. And your fact check buddy saying a functional concept today keeps your NCLEX RN fears away. So if you love this video, please don't forget to subscribe and hit the like and bell buttons. So let's learn together. For more instructional videos, subscribe to my YouTube channel, Gapuz Mentors, and my Facebook page, Mentor Ray. So see you and let's learn together through my YouTube channel. Happy learning. May all your dreams come true. I'm here with you guys, your support. Mentor Ray, your fact check buddy. See you in my next video.